Perspectives in Oral Health is a presentation of Tufts University School of Dental Medicine's Office of Continuing Education. Join us as we engage with leading experts, healthcare professionals, and thought leaders to unravel the latest advancements in science, dentistry, and the interconnected relationship between oral health and overall well-being. Without further ado, here is your host, Dr. Imran Awesome.
Hey everybody, welcome back to the Perspectives in Oral Health podcast, a Department of Continuing Education at the Tufts University School of Dental Medicine podcast. Today we have the chairman of the Department of Prosthodontics, Dr. Damian Lee. Thank you so much for joining us. Tell us a little bit about yourself and how you got to Tufts.
Yeah, thank you for having me. It's an honor to be here, and it's truly an honor to join such a prestigious university like Tufts University. I started teaching back in 2007. I was part of a pre-doctoral implant program at University of Illinois Chicago, where I taught for about 6-7 years, and then I was program director for the prosthodontic residency program in Ohio State University, and I did that for the last 11 years or so. The position was brought to my attention back about a year ago. And, I really had heard a lot of good things about Tufts University. It was one of the schools that I actually applied to when I was wanting to become a dental student. And so I always knew about the reputation and the great education that you can get. And also, City of Boston has a soft spot in my heart because my brother has been living here for the last 20 years. And my parents lived here for a few years before that as well, too. So I had visited Boston a lot, and, coming from a big city like Chicago and where I did my training as well, you understand the quality of patients that residents can learn from. And so I thought that it had a great opportunity, but also the reputation of the school and also having some family really attracted this position to me. So I just thought, why not? I'll give it a shot. And then here I am.
So I know you guys see a lot of patients in the prosthodontic department. If I was a patient, what would make me choose the prosthodontic department as opposed to seeing a general dentist in my local area? Sure.
When I came to visit Tufts University during my visit, I was very impressed with the facility that we have for the prosthodontic residents and also other facilities within the building. Dental schools can look and feel very different based on wherever you are living and attending. And not all schools have a very updated facility. I think that's a big testament to how much the school and the university is investing into patient care. So I was very impressed with the facility that we have for the dental students and the residents. And I was also very impressed with the amount of technology that we have in the prosthodontic clinic. And how that trickles down to other parts of the school as well. The program itself and how they update things and who they choose to partner with and how that impacts the resident education. I think you learn a lot from the fundamentals, but also it really helps the understanding and the learning if the technology enhances that learning. And that also then translates into patient care. So one example that I was very impressed with are these jaw tracking abilities from some of our technology that we have, and trying to incorporate into the movement of the jaw and how that impacts your restoration. And the design of the restoration really then focuses on the importance of occlusion and understanding the joint and how the jaw moves and how that then translates into the rehab itself for the patient. So those kind of things really was attractive to me. And I would assume that that also then becomes an advantage for patients to come to a school like Tufts for their care.
Yeah, I think I've noticed that we're definitely on the cutting edge of technology. And I feel like, especially in prosthodontics, like the technological revolution has been very significant for restorations, for implant dentistry. And I know you do a lot of research on that. So could patients expect this kind of technology when they come in to see you? Is that something that you guys offer at the prosthodontic clinic?
Yeah. So I think technology has really helped us through the patient workflow and really offering a good solution for patient care. Especially for people that don't like impressions. I think having an intraoral scan done is really easy and patient friendly approach to getting all the information that you need. And like some of the other workflow that we've been able to utilize technology has really enhanced the number of appointments and made it more efficient in some procedures, and really having the ability to generate the prosthesis and provisionals or mock-ups, and some of the setups and things like that to be digitized so that we can get it much quicker, faster.
Mm-hmm.
But also the really nice thing is to reproduce it
Mm-hmm.
when you have to make
Yeah,
it on
just
a
a
fly.
press
Yeah,
of a
you can
button.
press a button
Yeah.
and it can produce a whole nother
Right.
denture or another mock-up
Mm-hmm.
or provisionals. And, there would be hours where we sat next to the patient and would make it intraorally. But now you can, when your patient calls you and says, hey, I broke this full arch provisional, you could literally have another set ready,
Mm-hmm.
so that when your patient sits down, you can just unscrew it, put a new one in,
Mm-hmm.
and they can be on their way.
Yeah. So I think that has been a real revolution for us in our practice. But I think taking a bird's eye view, the full arch revolution in dentistry has been something that has been really valuable for me as a specialist, but I'm sure also as a prosthodontist, it's been really great to take these patients who have a terrible dentition, and through one appointment or even 5 appointments, completely revamp their whole mouth. And I know that you've done a lot of cases like that. Tell us a little bit about how you're doing that here in the process department.
So I think for full arch patients and really looking at terminal dentition, right? I think that's where we really need to focus on deciding whether that patient needs to be edentulated. I think, full arch and its benefits and the advantages of it offers a great deal of solution for our patients, but also making sure that we're taking the right patients and sort of going to that extreme, right? Because you're taking all their teeth out. But at the same time, if patient is at that terminal dentition stage, then full arch solution does provide a lot of options. And incorporating technology into that has really streamlined how we approach those patients with cone beam CT, with surgical planning, guided surgery, smile designs, having provisionals pre-made, and choosing the abutment on the spot. Having much more information provided for you before even lifting a finger on your patient, really enhances how we diagnose and treatment plan, but also then execute our overall treatment. Number of implants and those things still can be debatable, and where to place it and utilizing more bone here or there, grafting versus not grafting, all those things are pertinent information. But as a patient coming into a school and expecting what type of things can I get from a school versus other offices and things like that, I think really having the ability to digitize our patients, plan it, and execute that seamlessly, I think really enhances our experience here. And also, being able to walk out same day with certain things, and they look already, 100 times better.
I know.
As they walk in,
it's
right?
So life-changing.
It is. And you see the gratification, from the patient perspective, and obviously with our residents, when things go well, it's such a gratifying feeling that you accomplish so many things in one sitting. And as faculty too, you see the life-changing experiences and you're being part of that, and you're able to share that with your students and things. It's really a good experience.
Yeah. I mean, you guys get the toughest patients, right?
Right. So, It's really the complexity, but also managing those complexities. You know,
Mhm.
we have patients that are in care for more than a year, 2 years sometimes, you know, and it's trying to navigate through all the ups and downs within that time frame
Mhm.
because the demand that you might have, and it's not just aesthetics too, it's the functional demand, the comfort, all those things together.
Mhm.
You know, can you eat with it? Do you look good? Does it feel comfortable? Like if you can answer those three
Mhm.
during that whole period, you know, that's already a good thing. But it's also because of the fee that they pay and the time and the energy that went in,
Yeah.
they also want this to last
Yeah. Yeah.
as long as
The
possible.
margin for error is so much higher, or so much lower, I guess you could say, when you're going to a specialist.
Sure. And I think that's where, you know, a lot of the information that we take from the patient goes into um, the whole planning. And that's why we still use articulators.
Mhm.
And even if it's digital, we still try to um, put in the parameters for articulation into the digital software so that
Mhm.
we can account for jaw movements and things like that. You
Mhm.
know, understanding the guidance and how that's going to impact overall occlusal setup and changing the schemes of certain people. I think that's where the challenge really comes in because, you know, we don't function like an alligator where we bite up and down.
Mhm.
We chew in a teardrop fashion,
Mhm.
you know, and trying to make new occlusion for people that have had broken dentition is not as easy to design, but also execute, you
Yeah.
know, and you're trying to work with your laboratory partners, you know, to design what we feel like it's going to last for a long time with the material that we feel like it's the best for either that patient or someone, you know, who might be a bruxer, let's say, you know, so I think that's where, you know, in any rehab really, and more, you know, full arch things we do and more implant therapy we do and things like that, we're trying to make it last long as possible.
Mhm.
And, you know, you have to keep reminding yourself and the patients it's a replacement.
Mhm.
It'll never be as good as when you first had your teeth,
Mhm.
right? And with any type of prosthetics, there will be time for revision,
Mhm.
right? We get hips replaced, knee replaced. Those can always have revision.
Mhm.
And that's the same thing for teeth. You know,
Mhm.
we replace teeth with compatible material that we hope that it'll be compatible for that patient with good strength and also last for a long time,
Yeah.
you know.
I think that I appreciate the idea of teeth replacement being an idea that's not something that I have to sell a patient on anymore, right? Like now people fully expect to leave this world with all their teeth intact, right? And that's something that I've noticed is significantly different from when I started my training. Like, believe it or not, I'm 10 years into out of training. And I remember when we were in training, like we had to really sell people on like the fact like an implant is better than just removing the tooth. Do you find that in your practice, like the demographic is shifting now to people desiring this stuff more so than you having to convince somebody about it?
Right. And you know, I sometimes I don't have to sell it much because they already know what they
Mhm.
want.
Mhm.
But I think, you know, just nature alone, we have teeth that have been in our mouth for a long time. You know, you
Mhm.
have your 6 year molar and 12-year molar, and you have patients that are coming in with missing teeth. So they understand that I lost one tooth or two teeth here and it's impacting my function. You don't have to really sell it because they know the difference,
Mhm.
you know. And I think our predecessors and, you know, initiatives in so many parts of dentistry has educated our public very well,
Mhm.
and they've done a very good measure of keeping teeth healthy.
Mhm.
At the same time, we still have decay out there, we still have periodontal disease out there,
Mhm.
and we still have, you know, access to care issue.
Yeah.
You know, and you know, me coming into the New England um, area, you know, there's people that Massachusetts, New Hampshire, Vermont, you know, Maine, all with access of care issue.
Mhm.
So for these people, understanding that denture is not your gold standard for teeth replacement, but it is the minimal.
Mhm.
I think for them to understand that there's better things out there. And, I think that's why denture or the dental implants were created in the first place, because Dr. Bannermark didn't want people to, die with dentures in a cup,
Mhm.
and so I think that understanding even one or two implants can provide for someone who have no teeth they're using dentures. I think understanding that, you're investing into yourself to have something that's very retentive and long lasting versus a tube of Dexedent, let's say,
Yeah. Not
and
ideal.
right, but also the cost that goes into purchasing,
Mhm.
you know, adhesives for a lifetime still has some, investment. So I think it's more of how far can I stretch my dollar, right? And say, if I did get implants, you know, do I expect this to last as long as I use my denture?
Yeah.
You
I
know?
look at it as a technology, and when I talk to patients about it, George Washington had dentures, right? And that's a technology that has been tried and true for a long time, but we now have better options. And I feel like the implant revolution has arrived. It's becoming more commonplace. You have family in South Korea, you know that the adoption rate over there is much higher than in the US. What is the other revolutions that we're experiencing? I think digital dentistry is out there. 3D printing is out there. What do you feel like is really exciting for you being a prosthodontist, being on the cutting edge of this kind of stuff?
I think, additive technology and the quality that it's producing, I think it's still evolving.
Mm-hmm.
I'm finding out more and more that you can print multiple layers now, different material, different shades.
Mm.
Um, and then also the application of these technology is still continuing to evolve, which is very exciting.
Mm.
Um, and industry obviously is ahead of, what we're able to do for our patients and the type of technology that we're seeing. I think some of the 3D printing, not only resin, but ceramic and metal and biocompatible materials like bone and other things. I
Mm-hmm.
think that's really revolutionizing how we treat our patients,
Mm-hmm.
but also being able to reproduce things, right?
Mm-hmm.
So if someone, needed a denture reline, it's now quicker to just reprint a new denture
Absolutely.
with a new scan rather
Yeah.
than spending time grinding away those old,
Oh my gosh.
material.
I don't, that's one of the reasons I wanted to disagree. I know I wanted nothing to do with that stuff. But yeah, I think it's really exciting to be in dentistry right now. I have family that's physicians and dentists, and the expenditure for dental is going up. The number of dentists is pretty much staying the same. The amount of patients that we're seeing, I just feel like there's so many different things that are happening now. And one of the things that I think that is really exciting about being at an academic medical center is that you get to try all of these different technologies. You get to do research on all these different technologies and kind of find out what is the best, right? And so I know that you do a lot of research in other different areas. Tell me a little bit about the research that you're doing so that people can know, that, okay, like if I go to Dr. Lee, I'm going to get the best implant supported full prosthesis.
Yeah, so some of the research that I have been involved has been some retrospective patient outcome analysis. We've
Mhm.
done some research at institutions before, patients being treated by dental students and residents.
Mhm.
And a lot of my time I have spent with residents in the prosthodontic program. And so trying to track a lot of the things that have happened over the years.
Like you're talking
Almost
about outcomes.
yeah,
Yeah.
so patient clinical outcomes and so
Mhm.
forth. We've done some analysis in those.
So just
So
out of curiosity, like what, like obviously outcomes are better in the resident led treatment, right? Is that?
so residency programs are interesting because still some good guidelines on what makes a good resident patient versus a dental student patient versus a faculty or private practice patients. Residency, patients are still being treated by specialists in training, and they have good faculty sort of mentoring and overseeing a lot of the care. So you're still under the umbrellas of, your faculty mentors kind of overseeing and helping you along. So I feel like we, first of all, choose our patients very wisely and understanding the capacity of what our resident can handle, then we're not really pushing the envelope too much. So I think in, so many words, we're choosing the right patient care, for that resident level. And I think with, faculties calibrated and understanding what's a good dental school patient, then we are sort of choosing the right patients to treat. So I think that always then lead to better outcome because we're starting from a good point, right? So I think overall, we're making good clinical decisions, choosing the right patients. So I think clinical outcomes have been very positive in training programs. But it's also, it's a consistent place. If you see a lot of clinical trials and, other places where they produce a lot of clinical data, you're looking for consistency, and you're hoping that your faculty and the researchers are in the same place for a long time so that you can generate those things. But with electronic charts and, documenting with digital radiographs really makes it more streamlined to do clinical work and things like that. So even if, let's say, your primary investigator switches, if you have a good protocol, then you can keep moving forward with it. But some of the other ones that I've been involved in have been, doing some 3D printed materials, seeing
cool.
how they behave in light, with some aesthetics, with some durability things, with color changes.
Do you feel like the 3D printed materials are as durable as the traditional analog materials?
Right. So far, yes. But also the application, we're trying to make it as same as the conventional material. And there's some learning curve, I think, involved in 3D printed material, understanding how it behaves in the mouth, and can you add to it? Can you fix it? Do you have to use primers or bonding agents? Do you have to condition the surface before? How we use conventional material, there was a protocol because they've been used for many, many years. 3D printed materials, we're coming out with new ones, almost every day. And we're adding a lot of other materials to it, combining some things to it, being able to produce nanoceramic, resin final crown material right now, just 3D printing it, but we don't have a lot of clinical data behind it. So we don't know whether it can be repaired or should it be repaired or should it be replaced, all those things. And asking the clinical questions to do further research, we're sort of lagging behind because industry and the products are already out there. As soon as it clears FDA, then it's already produced, So whatever we're researching right now may not be applicable in 2-3 years, let's say, so whatever paper that we may have been reading, which is already about a year, late anyways, coming out to print, it may not be the latest information out there, right? And there may be already new product that address some of those things, right? So, if you're looking into 3D printing these things, it's more of, which latest one should I get? And is it going to be obsolete in a few years? What can this do for me and my patient? How does it fit into my office workflow? All those things. So we've done some of those research as well. And, there are other technologies, that are out there that I have sort of personal interest, which has been dental laser.
Oh, cool.
Yeah. And, in my old school that I was at Ohio State, we started doing a lot of laser applications to remove crowns.
Oh, interesting.
Yeah, on teeth or on implants.
Have you
And
heard the protocol to regrow bone around periimplantitis, the LAMAP protocol?
I'm not too familiar with it,
Yeah,
but periimplantitis is definitely out there.
yeah,
And managing implant patients
yeah,
is going to be a lifelong project
yeah,
for everyone in oral health
yeah,
because we sure did a lot of implants and we continue to do them, and there will always be implants
yeah.
now. You're going to have people already coming in with implants placed from several years ago to decades ago.
Mhm.
And you have patients with implants that are no longer being made. So removing it may not be the most feasible option for the patient.
Mhm.
We're trying to restore it might be even harder because we don't have parts for those, right?
Mhm.
So addressing bone loss around implants is going to be a key factor
Mhm.
because that may be the easiest solution to treat periimplantitis.
Yeah, I mean there's a lot of um there's a lot to learn about periimplantitis, and I agree it's going to be something that we have to figure out over the course of our careers. That being said, if you implants aside, if you have to have a crown, if you let's say fractured a cusp on number 19, what would you do?
Right. So my mouth actually has two crowns right now.
Okay,
I have
let me
a
guess, gold.
I have one gold
Heck yeah.
and I have one zirconia.
Okay.
So I had a gold. This wasn't actually an onlay. So I have a gold
Okay.
onlay
Okay.
where it's not very visible.
Uh-huh.
And at that time, because it's the most durable
Yeah.
life, I mean, very biocompatible,
Absolutely.
excellent margin,
Mhm.
adaptation. That's what I went with.
Mhm.
When I needed a crown where it's visible,
Mhm.
I sort of shied away
Yeah.
because, like any patients, I also worry about aesthetics.
Right.
So I went with zirconia at the time because it's very strong material. It's, more aesthetic than gold, obviously,
Mhm.
but the technology and the way that the crowns are made,
Mhm.
the margin adaptation is not as good as gold because
Mhm.
gold was so good, right?
Mhm. Mhm.
So it's been in my mouth for a few years now, and it's doing well,
Mhm.
and I'm curious to see how it performs in my own mouth,
Yeah.
right? So I think obviously, zirconia has been a big component of prosthodontics in the last several years,
Mhm.
ever since it came out. I think it sparked a lot of interest because it was sort of introduced as a new white gold type of material where you can keep it pretty thin,
Mhm.
and still have the strong and long lasting material.
Mhm.
And we use it as a substructure for a lot of things before it became a monolithic crown,
Mhm.
right? So we tried to put porcelain on top of it, and we saw that it didn't really quite work. So
Mhm.
then everybody started making it into one piece.
Mhm.
And nowadays they're mixing it up with some other material, making it more aesthetic and things like that. But really, the driving force behind zirconia really has been on the lab side
Mhm.
because being able to mill something at that time and produce something really fast and, just really changed how dental laboratories and technicians worked,
Mhm.
right? Because you're able to produce crowns much faster
Mhm.
and you're able to be more profitable with that
Yeah.
too, right? But I think at the same time you sort of start to have this mindset of, and it's like not just in dentistry but anything that relates to technology,
Mhm.
is it easier to fix or just to replace,
Mhm.
right? Like vacuum these days, it costs more to fix things than
Mhm.
to replace it, right?
Mhm.
And it's not the best fundamentals, but even for dentistry, sometimes we have to look at it and say, is it just easier to reproduce a crown
Mhm.
and just replace it versus trying to fix
Yeah.
something, right?
I definitely feel like, I mean, for us, we've really adopted 3D printing in our full arch prosthesis, and it's so much easier to replace it than it is to fix. In my
Right.
opinion.
And some of the materials that we're using, fixing it may be even harder
Mhm.
because it's not bonding the same way that your
Yeah.
regular, PMMA have done before, and you
Mhm.
were able to, repair it pretty easily. But
Yeah.
you can have a set of provisionals just waiting for your patient,
Mhm.
And
How do
then
you feel about zirconia full arches, like in regards to the the ones that are bonded to a metal substructure versus a full arch that's just completely made out of zirconia? Because I feel
right,
like those two are out there.
right. I think you have to sort of look at the type of complications you can have.
Hmm.
And zirconia being a very brittle ceramic-like material,
Hmm.
you know, the way it fractures is going to be catastrophic,
Hmm.
right? And you're not going to be able to really repair
Hmm.
zirconia predictably.
Hmm.
Some people are out there trying to you're trying to solder zirconia. There are some papers out there that talk about soldering zirconia. And it's a matter of, you know, when you have a prosthetic that is for the whole arch and you have, let's say, uneven thickness at places, right? And I think a lot right now with the mentality of doing more bone preservation and not removing bone as much as we did many years ago for full arch prosthesis, zirconia was a good material to sort of let us keep some more bone,
Hmm.
because bone around implant is still going to be very, very valuable,
Obviously.
right? So people that are doing more crown and bridge like FP1 style versus your conventional,
FP.
yeah, FP3 with 15 millimeter bone reduction, let's
Hmm.
say. More and more people are wanting to keep the bone
Hmm.
and seeing that because of the material that we're using, we can do FP1s much more predictably
Hmm.
and being able to preserve the bone, right?
Hmm.
And you can make it very aesthetic, make it look like the pontic is coming out of the tissue and things like that.
Hmm.
And with CAD CAM and digital planning, we can make it more predictable as well,
Yeah.
right? People that are sort of in between, let's say, we have seen where maybe the prosthetics, the thickness, let's say it's about 12 millimeters, sort of in between, right? And those patients we've seen work pretty well. But when it starts to get a little bit thinner and a little bit thinner, and you have the access hole for the screw
Hmm.
and around the area, the zirconia starts to
Right.
chip away or
Yeah.
break and things like that.
Yeah.
So having some kind of metal reinforcement we've seen, and and again, I'm sure there's many good research papers out there talking about the survival of one modality versus the other.
Yeah.
But I think it goes back to, if it did fracture, can I still put something over it, right? So if your full arch zirconia without metal reinforcement broke,
Yeah.
there's no way we can repair that. So it'll
Right.
be a new prosthesis.
Right.
But if it did have a metal substructure and you had a digital file, you can either reprint that portion
Hmm.
in as a provisional,
Hmm.
or you can re-mill that portion in zirconia as
Hmm.
well,
Hmm.
right? So it's really, if you have the file, that's what I think actually the labs start to, notice, is that not all the labs keep their file,
Yeah.
right? But let's say, they send it to you and you kept the file, right? You
Mhm.
can always reproduce that and being able to do that. And then, whether you have a very good bond between zirconia and titanium, I think that's for us to find out over the years, how long that will last.
Mhm.
But again, even if the cement layer failed, then it's such a smaller part of that overall prosthetic where it can be redone
Mhm.
fairly, simple, rather than taking the time to remill something or reproduce something.
Yeah. Yeah. It's very, very interesting to talk to somebody like you, because I feel like you have an understanding of biomaterials that me as a surgeon that I don't have. So I really appreciate you, kind of filling us in with some of the more technical aspects of prosthodontics. That being said, where do you see prosthodontics in 10 years? I feel like we've talked about a lot of different technologies, a lot of different revolutions that have happened in dentistry. Um, with two aspects. Number one, just general prosthodontics, but also just implants, because that's something that I feel like we've talked a lot about today.
Right. I feel like we're going to be headed towards a time when we're looking for solutions.
Mhm.
And I say that because not just in the United States, but all across the world, we're doing a lot of implants. And not all implants survive,
Mhm.
right? And whether it's an immediate failure or a delayed failure, you have percentages of things failing, and you multiply that by several million people.
Mhm.
It's a lot of patients coming in for revisions and replacements.
Mhm.
So I think what we'll see is, can you do another rehab on your patient or for your patient with what they have currently? And I think trying to sort of solve that riddle of patients having unknown implants, some teeth left. Do I just take everything out and start all over? But if I want to do that, do they even have the bone?
Mhm.
Do we have time and the resource to regrow these bone, or do we look for bone elsewhere in the mouth? I think that's why things like zygomatic implants and tuberosity implants or pterygoid implants.
Mhm.
I think those are going to be sort of more utilized.
Mhm.
But what if those fail?
Mhm.
I think we're looking at more and more challenges of patients are very used to and accustomed to having certain type of prosthetics, but you're running out of bone
Yeah.
somewhere, right? Whether, it's a hygiene issue, whether it's a material issue with a host issue, whatever it may be,
Mhm.
there's going to be some shelf life on these implants,
Absolutely.
So can we resolve that problem for that patient so that they can, live their lives? If it's single implant, I don't think that'll be a big issue, but let's say,
It's a
uh,
zygomatic implant. It's a big issue.
sure, right. It is a big issue, right? Because
Yeah.
they're already, challenged with
Yeah.
bone to start.
Right.
So,
Right.
things like that. I think the reconstructive world, our cancer patients and the maxillofacial world, I think those are going to be very patient friendly and more quality of life enhanced.
Mhm.
So I can definitely see more custom made for that patient. Even if it's a large defect,
Mhm.
they can try to scan the patient and digitize and plan and um, manufacture things that are
Yeah.
very custom for that patient as well.
Absolutely.
I think the materials that we use they're going to be more enhanced with different capacity. You can customize things, make it more aesthetic. I always thought that dentistry and like Hollywood makeup artists can combine
Yeah.
forces
Yeah.
in being able to produce, very good facial prosthetics.
Absolutely.
Um,
Do you do any maxillofacial prosthetics at all?
Not in my practice,
Yeah.
but I have a lot of interest in
Yeah.
that area. And I'm hoping to, collaborate more
Mhm.
at Tufts University here,
Mhm.
um, and being able to provide that option. And whether it's me going out and learning it
Mhm.
or bringing someone in that has that experience and being able to provide that care.
Mhm. Yeah.
But I'm, very interested.
It's that's another life-changing type of prosthodontic work that I feel like I've been a part of a few of those cases, and to see somebody go from a huge defect to something that nobody would ever notice that they're a cancer patient, that's really special. But last question, because I know that you're a busy man. If you had a dental student that's watching this and they were interested in prosthodontics, how would you advise them? And what would you say to somebody that's kind of like on the fence about, oh, I can't decide between
Sure.
general dentistry and prostate?
Right. So I think, and again, there's no specialty that's easier, but also prosthodontics become challenging because of some of the lab components that always been incorporated into it.
Mm-hmm.
And for dental students, I think during their time in school, it sort of becomes, I don't like lab work, therefore I do not like prosthodontics.
Mm-hmm.
And I really want to challenge that idea because the way we do lab work has evolved so much.
Mm-hmm.
So I would probably recommend prosthodontics for those that are problem solvers,
Mm-hmm.
that are thinking outside the box, that can apply new things and different things to solve same problems. Because when I was going through the residency program is vastly different than what is being taught now and what the residents can learn during their residency. So when I was at Ohio State and when we had our resident interview, there would be a lot of hands-on sort of tests that we would do
Mhm.
for the residents, which would involve prepping and temping typodonts and things like that.
Mhm.
But now I'm almost inclined to play video games with them,
Yeah.
right? Or
Yeah.
have them play Minecraft and
Yeah.
build something,
Yeah.
you know, and see whether they can navigate through things digitally.
Mhm.
Because, you know, I think the digital technology really enhances your experience as
Oh,
a
yeah.
prosthodontic resident, but also it can definitely save time.
Mhm.
I mean, it still involves time where you have to print something, do the alcohol bath,
Yeah, the
and cure it, right?
post-processing.
It's still time involved,
Yeah.
but it's more of, can I do this a little bit differently? Can I make it so that it's, you know, helpful for my learning, or try something different, right? And I think it's that curiosity
Mhm.
factor that would lead someone, in my opinion, to pursue prosthodontics. It's, you know, and I think the expectation at a school like this is, well, if I can't solve it, then I'm going to refer.
Mhm.
And that's always been the prosthodontics, right?
Mhm.
So you do get the challenging patients, you do get the difficult patients, complex patients,
Mhm.
right? That alone is a big challenge, right?
Mhm.
But it's also being able to apply all these other things that are available,
Mhm.
and also then work with other colleagues, because they'll come to you.
Mhm.
You know, they want to work with you and say, well, I need a good prosthodontist to work with me on this because it's going to be a difficult case, right?
Mhm.
So everybody understands where we fit in, you know. So if that's sort of the type of specialty you're looking for, you know, then I think it's definitely suitable for the future dentists out there.
Yeah, and it's definitely intellectually stimulating. I feel like that's something that I've seen just as a passive observer, having worked with a lot of prosthodontists. It's just, I mean, the before and afters are just really amazing. So kudos to you guys. Thank you so much for speaking with us. And thank you to all of you guys who are listening. For those of you guys who are listening on a regular basis, please like and subscribe. It really helps us out here at Tufts. So thanks, everybody. Hope you have a great one.